Record. So, hi everyone. Yeah, I'm Dermot Boyle. I'm the program manager for Nidus, so I'm responsible for the day-to-day management of the Nidus program. With a team of about 24 staff, seated in BSO ATS, and colleagues working across all the trusts and a raft of suppliers. So, alongside me today, I have Eilish Meehan. And Eilish is the HSE demographics manager, and she's responsible for the day-to-day running of the Nidus BAU service, so handling all the queries in relation to the demographics that come in. There's a team of 10 staff sitting in BSO ATS who look after that. So, yes, that's who your two presenters are for the afternoon. Some of you may know Nidus as DIS, but as part of standardization of the program, it was renamed Nidus about 18 months ago. So sometimes DIS gets confused with Nidus, and some of you who are here long enough may even know DIS as the Directorate of Information Systems, which predates me, but I'm well aware that that's often referred to. So we have a message from our SRO. I don't believe Louise can join us today, but she did pass on her thanks for everyone for participating and coming along. Louise, sorry? Sorry, I thought someone said Louise was there, but if not, Louise has been a fantastic ambassador for the programme and it's a constant source of challenge for the programme board and myself in making sure we're doing the right thing in the right way. And Louise really understands the importance of the health and care number to our patient pathways and clinicians and managing care for our patients. If there's a problem, Louise is always out in front of it as quickly as she can. So in terms of Nidus, what is Nidus? You've heard the name, but what does it actually mean? It's the new service being developed by the HSE to replace both the old health and care number known as Key. So if you've ever heard of Key or the stereo service, that's what it is. And the NHS system, which in Northern Ireland is used mainly for primary care registrations and cervical screening. Some of you who've ever worked in NHS England may know NHS has got much more use over there, but for Northern Ireland, we primarily use it to manage the registrations of our patients with our GPs and for cervical screening. Those are some smaller things in the past that would have used for organisation, but we also still use it here for medical care production. So as part of Nidus, we need to make sure that we don't throw the baby out with the bathwater, shall we say. We need to make sure that all them other sort of smaller services that we bring them across as well. The health and care number service itself is all really about managing each individual's unique identity within the healthcare, the HSE in Northern Ireland. So you obviously all know about the health and care number, which is your number for life from cradle to grave. But also along with that, there's lots of demographic information that we hold on you as a patient. And the HCN service managed that to make sure it is a trusted golden source of data and can be relied upon for all the patient demographics. And we'll come on to talk about that a little bit more in a short while. So why would we merge these two systems of the health and care number and the NHS service? Well, if you look at the databases, the two databases that underpin these, NHS and health and care, NHS is everybody who's registered for primary care in Northern Ireland, and health and care is everybody who's had an encounter with the HSE in Northern Ireland. So NHS is a slightly smaller database, health and care is slightly larger. So you can imagine the people who will be on health and care that's not an NHS, overseas nationals and visitors to the country who encounter our service and use our service, but aren't registered typically for primary care. And that's why NHS is used for screening programs. So not all screening programs, I should say, but for most of our cancer screening programs, it's relied on to identify the cohorts. And that's why cervical screening is actually going to potentially come into scope of NHS. So in the middle, we've got about 2 million patients. And I'll come on to talk about the data on the patients in a little while. But everybody that's here on the call, probably if you work for the HSE, you're normally registered in Northern Ireland, so you're on both services, on both databases, but your records might look slightly different just by the nature of how you engage with your primary care provider or how frequently you have to use our HSE services. Your records could look slightly different. I moved GP fairly recently, and I know that my record on NA is slightly different than my health and care record. That's normal, but as part of this process, we have to merge them. So there's a lot of similarity and commonality between these two services. And the other problem we have with them is they're on legacy technology stacks. So NHS is heading towards 30 years old and Key is no longer supported and sits in ancient hardware. It's not fair to say NHS is 30 years old. It's a bit like saying Oracle is 30 years old. Oracle as a technology, as a database management system, it's probably 30, 40 years old, but it's been evolved and kept up to date in that. NHS less so. So anytime in the last 10, 15 years, we needed to get a change made to either NHS or health and care. It was really, really difficult because of both the supply chain and also because of the skills to make these changes weren't there. And obviously as well, there's financial savings of this. So at the minute, if you think about it, we've got two support contracts, one for health and care and one for NHS. So simplifying and rationalising that should make this easier going forward. And we'll put in place a more nimble service so we're able to make changes to the new Nidus service ourselves, where typically in the past we would have had to reach out to partners organisations. So in terms of the objective of Nidus is to have this streamline the sharing of patient identity across the HSE linked systems, and Nidus will be the authoritative source of HSE demographics and GP registration information. What that effectively means is all the data will flow in from the other different regional systems into Nidus, and then it will broadcast out an orchestrated clean version of that record to all the different systems. So the digital strategy for Northern Ireland has 6 strategic outcomes. Nidus really underpins 4 of them, and we're a key enabler for the other 2. So it is pivotal and central to the functioning of the HSE, and indeed all the other digital programs are dependent on a cleansed record and a golden health and care number. To talk a little bit under the hood, because I do appreciate we've got lots of IT folk, I recognise a lot of names on the way in there who look after this stuff. So it's really built on an Oracle technology stack, and I'm not going to bore you going in and out of each of these bullet points, but just to know that the brains of the solution is Oracle with MPI, which is our master data platform. I'm going to have one brief slide on that, but the rest of the solution is also Oracle heavy. It's Oracle Apex for our front end, and the 2 middle ones, SoaSuite and BPM, are all about workflow and how we communicate outwards from Nidus platform itself. And then Oracle Access Management, that's all to do with the permissions we allow people on the data and on the system itself. And then we use Experian QAS to handle all the address cleansing. So you're probably well aware that some of the data that we capture upfront from our service users isn't perfect, and our addresses can be subject to some challenge in terms of quality and completeness of them. We use Experian QAS to clean all that up. I should say as well, DXE are our technology partner, who are the SI for this, and we're in a 10-year partnership with them. They're responsible for all the technology under the hood. As best we know it, this is the first deployment of an MDM in the HSE, and yeah, it's been a challenge, but it's been a good success story to date. So just to talk a little bit about master data management. Master data management is all about taking all the different views of your patient to come up with a single best record or single golden view of it. In simple terms, then, what we've bought here is a data model with some really clever algorithms for matching record and a bunch of tools to help us clean up and manage our data. So if you look on the left-hand side, you'll see that in the green data integration, that's all about the consumption of integrating and consuming the data, whether that's batch files overnight from, say, the GP practices or real-time, what we've got with PAS and Encompass. And then it's all about the data governance to make sure we have got the rules in place to make sure that we can accept data from these different systems. When you have the data in, it's all about mastering it, linking it together, merging it for patients that have got duplicate records, and the deterministic and fuzzy logic. So to give you an example of deterministic and fuzzy logic, whenever 2 systems are communicating together, you want them to do it in a deterministic way. So if it matches on a forename and surname and health and care number and date of birth 1-to-1, there's only one record for that search criteria, that's fine. Probabilistic matching and fuzzy logic comes in whereby we've got a user. So say one of our service users, one of our admin staff is trying to admit or register a patient, and they're looking, and I'm going to use Ailish in this example. They're searching for Ailish, but Ailish isn't known by Ailish to the service. She's known as Elizabeth. It uses intelligent matching to work out that Ailish is actually a derivative of the name Elizabeth, and that there's a typo in her date of birth. So it uses that intelligent matching to work out, here's a list of options for patients from our overall index of all the citizens in Northern Ireland. That is probably the one you're looking for. Now, obviously, that's risky to do for system-to-system communication where there is no user in front of it. So it's okay for super users to use it, but that's where we use it there. So as well as part of building that golden record, we have to standardize data and transform it and enrich it. I'll give you an example of that. It might be whereby we receive a message in for a patient, and that patient's record is missing the gender of the transaction on the way in, but we can see that their title is Miss or Mrs. or another female title, and all of their previous records received for that patient is for a female patient. Then it is safe to include the gender as female on that record. So we do a lot of work to cleanse that. Again, addresses, talking about it again briefly. If you imagine that we receive lots of addresses in different clean and unclean formats and over multiple numbers aligned, we use the QAS software to really structure that address, clean it up, and fit it into 4 address lines with a postcode. Sometimes you can get 6 address lines, sometimes 5, sometimes truncated, sometimes weird and wonderful addresses in, and that cleans it all up for us. And it's critical in doing that. In terms of how we're doing on our timeline, so the Nidus build was complete in January to build the the solution that was going to host our data, and we moved the health and care domain in September just past as part of that phase of go live that was, let's face it, all felt all a bit crazy for everyone, with NIPIMS and Nidus and Encompass all going live not long after NIPAX Plus. And it's a great credit to staff of all them programs. Everything went in relatively smoothly, and we are dealing with, and we'd be naive not to say, we are dealing with lots of different small teething issues and process changes that weren't well understood at the time. So just sorting out some of these as we go through. So the stars where we are on a journey. So we're moving towards primary care registration, which is all that NHS functionality, with an aspiration to have it live for spring 2026. So we have a bunch of functionality we're delivering still at the minute from phase one, which is all the stuff that we descoped to go live, and then some stuff that we've seen since going live. I think that actually could work better for us. The grand plan is then to also deliver cervical screening, subject to business case approval, for spring 2026 as well. And then the program will close after the completion of the primary care registration and cervical screening. But that's not to say Nidus itself is closed for business and we're not going to do that more. Obviously, the HSE plans to do much more. A good example is the Go Pharmacy NI program. As part of that, patients will have the ability to register their preferred pharmacy, and that means that whenever they order a script at their GP practice, they can collect it from the preferred pharmacy. It makes perfect sense to hold patients' preferred pharmacy in Nidus so that that data is available to more than just the GP, but to secondary care as well. And that's what we're doing. So a lot of this stuff will come in through BAUs as we move forward. So with that, I'm going to pass over to Eilish to talk about the challenges for the HCN service. And yeah, Eilish can take it from here for a while.
Well, I'm Mail, which you probably know me because I've been around from 2004 when we brought the health and care number in and started. So we're back doing the same challenges again of bringing the health and care number into more systems than we have at present. One of the biggest challenges we have is that we've replaced all the local systems with regional ones, which have more of a capability to share information and the types of information that they can share. So all our existing sharing protocols and guidelines will have to be revisited. So you'll be seeing a lot more of my editors. Some of the misconceptions that we say we've got the golden record in Nidus, but Nidus really only controls the allocation of a health and care number based on the request from any of the services. It consumes the information from the linked systems and cascades that down to other systems. Therefore, our information is only as good as the information we receive from the systems that feed us. Nidus is a hub for the creation of the patient's golden record, and it is pivotal in the dissemination of the patient demographics across all the systems. So our team really does take their job seriously, and that's when you may get delays, because what we do is we validate the information on that golden record before we send it out to anyone else. And that's going to be, important for the new digital informatics environment. So as the health and care number is vital for linking patient records across the systems, we have to make sure that we can get that information to the service providers in a timely manner. But we have to make sure that we are getting the right information. We need on the next slide, Dermot. He's controlling the slides, being the boss. So as Dermot has mentioned, right, I am on slide. Wrong slide here for me. Right. Patients have believed in the past that when they went into their GP or went into the hospital and updated their information, that it went automatically down to anyone else that was interested in them. And that was not the case. But now with Nidus, because we are now linked to more systems, in the past we were only linked to PAS and the GP systems, we have more of a reach now into NIPAX, into NIPIMS and other systems, and we'll have more of a reach going into the future. That will not be the case. We will be able to update the patient's information as close to real times as we validated it. So that will improve that service for us. We will also have an extended data set being introduced in phase 2, which will also allow community and secondary care to see what the status is for a patient in primary care, whether they are entitled, whether they've gone away, whether there's any, who their latest GP is, and they can look straight into the system and see that up to now, NHAS, which is the GP registration system, has been closed and not viewable to anyone else in the service. We will also have other additional data items that were previously held in siloed systems. Things like ethnicity that only a few systems would hold, but now will be viewable to more and more services that maybe require that information because it would be held centrally. And when the patient gets it updates, it's updated once. It's held in that central location that is viewable. So we're not going to keep asking the patient for the same information over and over again. And also that in future, Nidus has the potential to act as a hub for more than just patient identifiers. As Dermot had said, there's things that are about being able to, have pharmacists in there to link the patient with the pharmacist. There's also the ability maybe to be able to digitally have your medical card on your phone as opposed to having it on the card that goes out to you. And also the patient will have more of an opportunity to be able to interact with the central index that isn't available at the moment. I'm going to move on to the next slide, Dermot. Which is good. Sorry, I have to play catch up because we're not sharing it. So with the result of more intelligent matching, that means that the first time hit rate for health staff searching for a health and care number will be more efficient, and there'll be less fragmented records to be managed, much more cost effective and definitely safer for the patient. One of the things we keep getting asked about is why we don't give a health and care number at that point of contact with the patient in the first point. The value of the health and care index and the health and care number and Nidus is that it's a back office validated record, which guards against all those duplicates that we know have been created on everybody's system. Because the first time you go in contact with a patient, you're just taking the information to get them on the system, to get them treated. You don't actually know who the patient really is until a clinician or a provider is actually starting to treat that patient when you're doing and validating their information. So the Nidus team monitors changes in demographics received from all those systems and aggregates that information. And from that, we can identify issues with the quality of the data being received and identify areas where those issues are arising. And therefore, we can then advise at local and regional levels what steps need to be taken to improve that data. So as we move forward, the data will improve and the golden record will be the golden record. I mean, as before, we had 8 passes, all worked in as siloed systems. That will move into Encompass, where we will have one record there. All those siloed lab systems that didn't talk to each other are now going to be in NowPIMS. And that work has already been underway for a number of years with NowPACS. And as more systems come on and they can all look into that central hub, then we can all cooperate with each other in order to ensure we've got the most up-to-date data and a way of actually changing or correcting data in real time as much as we can. With the introduction of phase 2, we will also have all that GP registration. At the moment, there's a delay between Nidus receiving the update of when a patient has moved GPs and when we can actually cascade that information out to the downstream systems. In the future, once phase 2 is in place, that will be just as real time as the health and care number will be. Have a hand back to Dermot for the next slide.
Nope.
The challenges of the program.
So you covered off the slide as well, Nidus, yeah?
Yeah. Okay. Yeah. With a challenges ahead of the program, and then I was going to the next slide problem, after that.
Yeah. So the challenges that we have coming up are really around the merging of health and care and NHAS data. There's 2 million records to be reconciled across both data sets now. They are the same people, but the records are going to look slightly different, and we need to make sure we can take on the most recent information for them patients. That will be challenging task. We need to look at the integrating the service screening. It is a complex call recall service, and it's been in NHS for a considerable period of time, and it is going under considerable change as well. To move recently to primary HPV, and then with the introduction of now PIMS, or LIMS, I should say, for the management of the clinical back end of that. Coping with scope creep, I think this isn't new to any program. Anybody who's ever delivered a program knows, or project knows, that scope creep is the devil. And really, whilst Nidus, we can see all the different benefits people are bringing to us and some of the challenges that they're bringing to us. We want to help, but we have to be firm about what our scope is, but be open-minded about the future. So I'll give you a good example of that is we're transforming how the patient registration process works with primary care. So the FPS team will have better tools to manage them registration processes. That puts us on the cusp of maybe allowing patients to register for a GP through a portal rather than the current process of you print out a form and you bring it to the new GP practice to fill it in and the police complete all the processes at the practice and then send it in. We could enable a portal as part of this. It makes perfect sense to do it at a time like this when you've got a program team stood up, when you've got all the structures and governance in place, and you do it as an addition to the program, but it isn't part of our current scope. But we want to be open-minded to what the future can bring, so we're open to these ideas. The other bit of it is around the business processes, and it has been a challenge recently. You guys touched on the fact that Encompass has come online, and now PIMS and now PAX Plus has come online. And there's process harmonization challenges there that maybe we hadn't seen before, or nobody'd seen before, around how in the day Encompass has a patient index, where in the past PAS had a XPR, which is a local copy. So we're updating in real time into Encompass, and that causes some potential issues for Encompass records that are being updated. And perhaps the update isn't welcome, for want of a better description, on the Encompass side. So we're fully cognizant of that, and we realise that we're passing that data from other parties in, and that's potentially causing impacts. Some of it's good impact, some of it's bad impact. So we're trying to manage each of these whilst also moving on to phase 2. So it isn't without its challenges. I was at the Encompass Lessons Learned session yesterday in Dunadry, and they mentioned how they had the euphoria of going live with Southeastern Trust first, and then it's time to maintain the momentum. We can recognise that. We've laser focused on getting Nidus live, but we need to maintain it, but also focus on these process issues and all the other stuff that's going to come along in phase 2. So it is a challenging time trying to keep everything moving forward, but it is something we're reasonably comfortable with. In terms of if people are interested in helping or wanting to get involved, there's lots of different areas that we're keen to gain as much from our stakeholders as possible. We have a new API that we're developing. Some of you may know or have heard of the generic interface. It's used by approximately 80 systems out there to, under the hood, make a call to the Nidus service to get the latest demographics for health and our care number for a patient. We have to deliver a new API for moving forward into the new era that we're in that can be called by more systems. So at the minute, the interface is relatively, I wouldn't say basic, but it's very Northern Ireland specific. But if you look at our product vendors, they're all using FHIR or industry standard messaging, but we weren't. So we want to build out these new interfaces that will make it easier for new programs and new services and our service users to come along and integrate with our data. So we're at the process at the minute of trying to spec out what our new APIs are going to look like. So if anybody has input into it, we'd be more than welcome their input into the process. In addition, we're looking to capture additional information on patients that we can. Nidus has always been, or health and care has always been about non-clinical information, but there is information that perhaps we could capture on, for example, languages that people speak, or their blood group, or their ethnicity, as Eilish has captured. Now, all this is fine, but we do need to identify trusted sources of this information. We typically try to deal only with trusted sources of data. Some sources are not trusted sources. For that, I'll give you an example that the GPs will be trusted sources for a forename and surname because they've verified a patient's passport as part of the registration process. Where other sources, maybe like say PAS and the addresses, quite often they're updated without actually viewing a patient's, like, I don't know, proof of address. So, but we do want to capture more information as best we can. And we are all open to suggestions for improvement. Nidus is for everybody in the HSE, and we want to make sure that we provide the best service that we can. So any suggestions for improvement, we would gladly take on. And that is me, and that is Eilish. So if you have any questions, there's our office email address, or you can contact us directly at any time. We're more than happy to take questions.
We've got Breed Farrell there, has her hand up.
hybrid.
Thanks, Dermot. That was very interesting, and I think I'm meeting you next week about a couple of things.
That's right.
Just wanted to know, given that we've had sort of essentially the simultaneous introduction of 5 systems, how was user acceptance testing carried out for Nidus?
So that's a good question, Breed. So the testing regime for Nidus was, in the first instance, was done by the program team along with the supplier, and then passed out to each of the trusts to test for each of their systems that they are connected and integrate with. So it's only on sign off from the respective trusts on the other regional programs then that we stepped through into having a live service.
Yeah, and then my supplementary question is, in terms of merging records, I mean, you know, people sometimes call their twins, you know, Dennis and Denise. Your probabilistic matching process, you know, could easily run into difficulties in that scenario. How are you going to get over those?
Yeah, so probabilistic matching wouldn't be used in merging of patient records. That would just be a red line that we wouldn't cross. Yeah, it's manual and it's done by data quality users in the leadership team, so there would never be a scenario where we're automatically matching 2 records in the background, because that's too much risk.
Okay.
And I think also, Brad, you'll find that we are now moving in where we have community systems now moving in using what is essentially been an acute system. There's different tensions there about how they manage data, which is coming across now once we start merging those 2 service areas together. That's where we have to start and revisit all our guidance and all our protocols in order to do this safely.
Thanks, guys. Anyone else? Any more questions? We did have one in the chat, which Dermot has answered there from Gary, if anyone does want to go have a look. But by all means, anyone else want to raise their hand? Any more questions? Gary, you have another one? Go ahead.
Yeah, thanks, man. Dermot, Eilish, great work, by the way. Fantastic. Good to see that continuity. 20 odd years, I think, since the original implementation, isn't it?
Yep.
Yeah.
2004.
Yeah, 20 years. Very good. And well done. Congratulations. Just a couple of questions. One was on the NHAs being used for the demographic extract for a lot of the screening programs. In terms of the decommissioning as such of NHAs and the transfer to Nidus, is that extracting process remaining with Nidus, and are all the screening programs involved in that discussion?
Short answer, Gary, is yes. So we're going to replicate the extracts. Yeah, we're going to replace the extracts. Just on that, we are considering the option as part of that is creating we'll call it a screening index, and then it meets the needs of the screening. So we don't want, you could potentially end up making changes to Nidus to basically facilitate the screening. So it's better we create an extract solely for screening, and then screening draws from that what they need.
We offering to do screening functionality in there then?
Am I offering to do it? Yeah,
it makes kind of sense. It does make kind of sense. I mean, all it is a question of a cohort, really.
Yeah,
it's an algorithm.
That
produces.
When you look at what 100%, but you look at what Nidus is and what a screening program is. Screening program is identify a cohort and bring them through a workflow process. Nidus is a population index and a workflow engine. So in terms of compatibility, they're very aligned. My only caveat on that is I would never like us to make a decision that undermines the data management with the primary purpose of Nidus, which is about identifying our population index and managing that population index and the primary care registration. But we're totally open to these sort of suggestions.
And on that, at least just from your own information, you'd mentioned some of the Encompass challenges, and I guess when it was established, a lot of the thought process would have been you're removing, and I know we're only at SAT, you're removing 8 PAS systems, one of the main causes of pain at for the index in the early days and latterly. And with the introduction of order sets and a single demographic set within Encompass, it was envisaged the accuracy of data and the need to mutually update it would have been reduced. When you were mentioning there were some process issues, is that kind of part of it, or is there,
Yeah,
are you foreseeing it won't be reduced?
Yeah, well, number one, we're closing down NIMATs, which is, and all our protocols have been designed around the NIMATs functionality that will automatically kick off a registration once the child has been born. Then the Encompass one is Stork, which I don't know yet, so I'm getting a visit to find out exactly how it works. The other issue is that downstream systems like NIPIMS hold less characters than Encompass or Nidus. So how do we make sure that that's a straightforward flow of information? So if you're going to do a blood transfusion, they can only take 30 characters, where Nidus and Encompass can take more, 40 or more. So how do you, what are the protocols in there? You know, you have the wristband, which will have the full name on it. The order comms, which unless if it's 31 characters, will just be disregarded by that system. So all of that has to be worked out again, and new protocols and guidelines and standards reestablished and written up.
Is it foreseeable in that? Sorry for hogging it. I do have an interest in this stuff.
Yeah.
Is it foreseeable in that we get the imposition of mutual trust between general practice, a regional Encompass system, and the central index, where they all trust the updates from and to each other?
Eventually, when you've got enough evidence to prove it.
Fair enough. But would that be in the plan so that it reduces the burden on the centre to keep that up to date, that we have 3 trusted sources which act as a union, in union, or one trusted source in effect?
No, as Dermot has said, that we look for each data item to have an authority with it, and they are the authority that can update that item. But you know, we're a long way off that yet. So that's where the ultimate aim is. You know, we want the free flow of information, but just as information flows fast, good information flows fast, so does bad information, and it's a lot harder to pull it back when it's went downstream so quickly.
As long as we're consistently right or wrong,
yeah, not necessarily. If you want to make sure that the clinician is looking at the right record for a patient.
Yeah. No, look, thanks very much, Dermot Nidus, and congratulations again on getting it live. It was a hard job, no doubt. Thank you.
Thank you, Gary.
Thanks very much, guys. And one last shout out, really, if anybody else has any questions they want to raise their hand at all.
Yeah, I'm happy to stay on for the last 20 minutes if anybody's any questions they want to ask in front of the group, but
yeah. And
more than happy to stay on.
And Dermot has also put up there the email address for anyone that perhaps wants any further queries answered. You can always email the guys.
And also, as because we're going to be looking at the new changes in protocols, the data quality team will be going out to different organisations just so we understand their systems. So any invites, we'll take them.
That's great. Thanks very much, guys. So yes, I think for anyone that wants to stay on to ask any questions, you're more than welcome. Otherwise, really just like to thank Dermot and Eilish for coming along today to give us a presentation. Really interesting. Also, Dermot, you mentioned phase 2.
Yes.
And
yes. Sorry. Yeah, thank you for reminding me of
okay?
yes. So phase 2. Yes, I did say it before everybody came on that we are actually just embarking on phase 2 now, and that we plan to come back at the end of phase 2 to give a recap on how we got on, what we've learned, and what we've changed, and just to give everyone a bit of an update on Nidus and how things are going. So yeah, we will be back.
That would be good. So watch out. That will be promoted through all your various comms channels to advertise that one. And just a little reminder, we go back to the first Friday for next month for May, and Dan West, the Chief Digital Information Officer for the Department of Health, will be doing a little recap on the implementation of our digital strategy and where we are with some of the rest of the digital programs. Nothing in depth for any of the particular programs, but just an overview of timescales and what we can expect in the implementation of the strategy. Yes, again, recording of this will go up on YouTube. Look out for it at the end of next week, and that'll go on the DHCNI YouTube channel. And that's it from us today. Thanks very much. Say anyone wants to stay on, by all means do so. Thank you.